Does anybody else have like any questions?
I would love to know how different people are doing their fees for the piezo wave. I mean, if that's okay to ask.
For me, it's very demographic and what your how you guys can make it work in your area. I know we were just talking about the fact that Dr. Grubb is moved from Denver to the country, and we having to be more creative, which is reasonable for sure. I know that one thing that people have started, which I think is useful in the pricing, is a geriatric or I hate to say palliative care, I guess a geriatric pricing,
Mhm.
at a little bit of making it more reasonable so they keep coming back, keep them comfortable in their senior years.
Yeah, it's that's a good idea. I basically came up with this anything goes package. I didn't know what else to call it. And so it basically says it lets me do anything I want. And
Yeah,
and
that's what Dr. Taraka always does. Yeah, just
some people have really just been fascinated with the anything goes, even though it is pricier, but I try to make it much more affordable. So I can, do shockwave, I can put them in the water, I can do all those different things.
yeah, whatever they need in that time slot.
Yeah.
Yeah, that's good. Awesome. And some people are charging long, short, or short, medium, long, and other are charging by how many areas they're treating, and others are incorporating it into their, as we talked about it, everything goes, hour treatment or a half hour treatment. But I always try to give a few parameters when pricing, and I feel like we need to price more than laser, perhaps twice, depending on where you're at in that world. But we don't treat as much, and we are equally or more effective. So I feel like that's a fair game. And then the other thing I like to keep in mind is if you if you have acupuncture at your clinic or you are doing acupuncture yourself, I believe we should be slightly less than an acupuncture treatment because it can be run by a technician. So those are kind of those are two parameters that I always give to help you work through that situation. What I'm trying to get Dr. Strubel to do for us today is talk a little bit about her hip protocol, because we are in the process of working on a multi-centered hip study. So I was hoping that she could go over the four or five areas that we're planning on treating and what and why around the hip. So are any of you guys treating hips?
I treated it on acupuncture points, so like bladder 54, gallbladder 30 and 29,
Mm-hmm.
and did like 600 pulses per spot.
Okay.
I feel like it really helped.
It really helped.
Yeah.
Good. I know a lot of people who have been using, I'm not trained in acupuncture as a technician. I just sit and watch the courses. But I have heard a lot of people having good luck with the acupuncture points. One of the biggest issues we have is the muscle groups. One, the muscle groups, and two, the getting into the hip joint takes a pretty specific angle, right? Because you have that kind of a cusp over the ball and socket joint. So those are my two, kind of things that I think we have to be attentive of when working on the hip. Also, we know shock wave on bone can be very sensitive. So I try not to actually hit the greater trochanter or the acetabulum. So now you're kind of like shooting at puzzle pieces. But, you can kind of get it into the joint line. People have different entry points into the joint line. And once you're in the joint line, I think it's important to remember that we don't have to run it everywhere in the joint line if we're looking for synovial fluid and getting the actual anti-inflammatory effects within the joint. So once we're in there, it's okay to hold it still. That's up to you. I know Dr. Strubel really doesn't like to hold things still, but I'm not against it. You know, it's a as you would like situation for sure. But then the hip flexors and hip extenders do play a huge role, right? So most hip patients or hip OA patients that I handle, which is not as much as you guys, so you guys can chime in here, is the hip flexors are just cramped because they've been holding it up and not putting full weight on it or using a full range of motion. Is that something that you guys have found?
Yeah.
Okay. So I do work on those muscles and running through the fascia and the muscle groups. And I do it moving very slowly, and am not against doing 400 to 500 pulses and stopping and giving it a gentle stretch, and then continuing on with another 400 to 500 pulses in that muscle group.
So when you're going through the muscle groups, and I'm still kind of new to piezo wave, is the thought process that you're kind of breaking up the myofascial kind of knots and tightnesses, and then if that's the goal, what is the, like, do you use the same size gel pad that you would for trying to get into the joint, or would you use something more superficial, more like superficial?
So when I work through the muscles, yes, I'm trying to release the fascia and hit the trigger points. And if I hit a trigger point, I do stay on it. The one other thing I want to finish with this one answer is, don't be hesitant to change your gel pads during the treatments and stacking them at different gel pads. That's another thing that some people are finding a big success. Then I will introduce Dr. Strubel. She is a longtime piezo wave user. She's done amazing things, and she's helping us on this hip study.
I'm late because appointments back to back, and I didn't give myself a break between appointments and this Zoom. So I'm so sorry.
No, we were just kind of talking about treating the hip and the muscle groups, which we know you love to do.
I do.
Let's hear what you have to say about how you're treating hips for this hip study, because I want to learn too.
Yes, so I definitely would say that, well, right now we're treating a piezo wave hip study patient in the other room. And for me to know whether it's sham or real, I have to actually sometimes be in another room or take out my hearing aids while my techs are doing the unblinded technician is doing the treatment, because I can tell the difference between sham and real with the sound, how loud it is with the clicking, with the gel, without the gel. But I have almost 10 patients. I've got one more to go for the study. And the reason I wanted to do the study in the first place is because I felt that piezo wave wasn't being used in a way that it could be. I felt like many more patients would benefit from treating the surrounding musculature, not just a joint or not just a tendon or not just a ligament. And before there was the manual that has been created, I still use it very differently from the manual. I don't really just keep it in one place. I do fan through the tissue. And when I treat a hip, it's not just the hip joint that has pain. It's all of the myofascial tightness and hardening and restrictions, all the muscles that attach to that greater trochanter, and medially, laterally, just everywhere. And so especially, your adductors, your proximal sartorius and rectus femoris, your pectineus. And then of course you have tremendous atrophy. If it's a chronic patient with chronic hip dysplasia, an older dog, you're going to have a lot of muscle contracture. So you lose your range of motion, and so they're much more painful doing any kind of therapeutic exercise or manual therapy. And so I started to use the piezo wave to treat any arthritic joint, elbow, hip, stifle any chronic joint where there was a lot of muscle tightness, contracture, and atrophy, to get blood flow back in, and to treat any trigger points that you could palpate, but also remembering that there's the tension in the muscle as it atrophies, there's less blood flow, and that chronic muscle, contracture is painful, like chronic pain, achiness from the, I believe that chronic pain lives in the fascia. And when your fascia is tight and squeezing all the time, and the muscles are being squeezed from tightness, you're going to have chronic pain. And PiezoWave immediately relieves that. I know that from treating myself, but also from the response of the patients. And so I really wanted to try to get a study done together with Cindy when the pandemic hit and we were closed for a few months. I said, oh, great, I have all the time in the world right now. Let me work on it. And then, of course, once we got it up and running, everybody hit the ground running and was so busy once we reopened. But it's taken a while to find the right patients to fit the criteria, because in order for this to really focus on hip pain, to show that PiezoWave helps tremendously with hip pain patients, increases hip range of motion, increases weight bearing on the leg, increases muscle mass, we had to really isolate the source of the pain to the hip. So you're dealing with patients that have pain in the spine, LS disease, stifle arthritis, tarsal arthritis. So if they have lameness for other reasons, that kind of excludes them from the study. But to enroll a patient in the study, I've found the other criteria that has to be there is the client has to recognize pain in the patient. So for example, I've had a number of young dogs referred to me by vets because I advertised to the vet community. And I see Anne here, and I think I owe you, Anne, a copy of my announcement to the vet community that we put out there to let them know that we're doing the study and refer cases to us. So we would get some young dogs that had radiographic evidence of hip dysplasia that were found sort of incidentally sometimes. The owners weren't even aware they had tremendous hip dysplasia, and they aren't really candidates for the study if the clients really can't recognize any abnormality in function or discomfort in their animal, because they have to be able to identify at least 3 outcome measures that you can say before and after. Does the client feel they've improved in their ability to do these functions? And also their client brief pain inventory. They have to be able to assess whether they have pain or not. So that's another thing that I found a limiting factor. I had one patient all signed up based on radiographic hip dysplasia. And when I met her dog, he wasn't very obvious to her having pain. To me, I could see the waddle, I could see the abnormal gait, but she couldn't really tell me anything that he couldn't do. And I watched him extend his hips all the way and do all kinds of things. So it's kind of like, well, I guess we can't measure the before and after if there's no before problems. So I do find that treating the muscles, fanning through the tissue, I get much better range of motion, much better results with my patients. And so the study is we're designing it to be as controlled as possible, to limit the variables as much as possible, to be double blinded, the surgeon who's evaluating the gait videos, and then the vet, myself, doing the measurements, or the PT doing the measurements. We are all kind of, we don't know whether it's sham or real, and we don't find out till I call it the reveal appointment. And then at the reveal appointment, we find out if it was sham or real. And usually my techs who were doing it, everyone can see the difference in the patients that were real. The sham patients, not so much. So I'm hoping that the data will reflect what we're seeing.
So Dr. Strubel, when we started talking, I was saying, the hardest thing or one of the hard things for this is that we all use the PiezoWave different, but for the study, we all have to try to stay as same as possible. So can you go over we picked like 4 different areas of the hip that we were treating?
Yeah, so
we did.
Yeah, let me grab one of the patient binders, and I'm not allowed to look. The sticker goes in whether it's sham or real, so we've covered it with a sticky note so I don't accidentally turn the page and see if the patient has a sham or real sticker. But the treatment area is that we decided on was literally the hip joint capsule, and I'm approaching that from the lateral aspect, from the caudal aspect, not medially. The gluteals, the biceps femoris, tensor fascia lata, and proximal quads. So basically any of the muscles just proximal to the hip and the pectineus and adductor muscles. If you can get in there, it's hard sometimes if they're really tight. In bilateral cases, I'll have them stand or I'll have them lying on their side for belly rubs where they maybe open their leg up just a little bit so we can get the probe in on the down leg, on the medial aspect. And we are using, the gel pads will vary with the patient size. So using common sense about, if you're trying to get into a muscle, usually I'm going with a 10 millimeter for the medium small dogs, and maybe a 15 if it's a very large dog or has a lot of fat. Most of them don't have a lot of muscle mass because they have chronic hip dysplasia or hip pain. We're using a standard intensity of 6, and that on the F7 G3. Our F7 G3 gets to the moderate energy range around 12 to 13 on the settings. So I found, and I rarely use 12 to 13 on these hip cases, I found that the low energy pulses provide tremendous pain relief. So it's not true that you need to have more energy or more higher intensity shock wave to affect improvement and pain relief.
And about how many pulses are so we have 4 areas, about how many pulses are we doing in each area?
Each side, so we're treating both sides, whether that both sides have documented hip dysplasia or not, we're treating both sides. Number of pulses is 1,000 per site. So it's like, it ends up being 4,000 per leg. So a total of 8,000. And at the, and we didn't set the pulse rate, the hertz, but I'm using 8, the maximum. And I'm using 8 on almost all of my patients simply because I can get more pulses in per treatment. And so it takes about a half an hour to treat with 8,000 pulses, both sides. And I have my technicians doing it. They know their anatomy, they've been trained, they know where to treat, and they're fanning through the glutes, or they're like slowly moving it around. They're not zipping around, and they're holding it in place over the hip, the joint capsule. And so they're doing region by region by region. And for the most part, the patients have tolerated that. I have had patients in the past that would not necessarily tolerate 6 intensity in the start of a treatment with chronic hip pain. But so far we've been with muscles, I find they tolerate that. But when you get to the muscle tendon junction or over the joint capsule where there's more dense fibrous tissue, it's absorbed much more intensely and it's a much more intense feeling. So some of these, I haven't had it happen yet, but we might, like within a treatment session, work up to 6, like start at 1, slowly go up to 2, because that I find that if you start low and you work your way up to your target intensity, you block some of the pain fibers. So it's like doing a local block in a way. So you can start lower and relieve some of the acute pain, and then you can work your way up because you've inhibited some of those little chronic pain fibers in the fascia, and you can go up to your 6 intensity.
So Dr. Strubel, we need to get you upgraded because the new machine ramps up. You have a ramp program. So we are starting to do that more and more, and we're doing that on the human side now, where you can actually, the new machine allows you to set it to ramp like from 1 to 6 over however many seconds you want it to go.
Oh, that's interesting. Okay.
We're working on that on the human side, and also because the question of, do we get habituation? So they're studying that on the human side, but any of you guys that have the touch unit, that is something you can set on your unit. The other thing with the touch unit, if you're in a hurry and you're doing the muscles, you can go up to 12 with your frequency. I do not recommend going that high ever in a joint because it hurts. So
it depends on your depth of your probe. So for the purpose of the study, we're using 1 gel pad depth for the entire study. But like Cindy, you were saying at the start of when I jumped into the Zoom, that we switch pads during treatment. So if I'm targeting, for example, if I'm doing a biceps tendinopathy case, the shoulder, I'll use a 5 to go right over the biceps tendon and the joint capsule, the shoulder joint, maybe the rest of the supraspinatus, infraspinatus, all the tendons that are palpable superficially in that area to treat that. But then to get up, if it's a large dog, I'll treat the muscles that surround that joint, like your pectorals, your supraspinatus muscle, your triceps. And I go into a deeper pad, like 10 to 15, depending on the size of the dog. Because if you just treat your biceps tendon, but you don't treat all the painful contracted muscles around that shoulder, and if it's a biceps tendinopathy, what's going to happen to your biceps muscle? Your biceps muscle is tight and trigger points. And what's going to happen to supraspinatus? Because it's working overtime. And it's rarely just one tendon that's affected. They both cross the joint, crisscross right there. So if I'm treating a supraspinatus tendinopathy, I'll work my way up into the belly of the supraspinatus muscle as well. So I'll try to target about 750 to 1,000 pulses to the tendon of the target tissue that's injured, but I'll work my way around it and treat the muscles of that. And then I'll use the rest of my time and the rest of my appointment to treat any other myofascial pain I find on that dog, because they're all compensating. If they have a painful hip or a painful shoulder, they're shifting their weight. Now, for the purpose of the study, we're not doing any of that. We're not treating trigger points in their lats, their shoulder, their front, their neck, the TL spine, but they all have that because of their chronic postural changes, right? So when you're done with the study, I would not just treat a patient one target tissue and then that's it. They get a half-hour treatment no matter what that we're doing, and we treat multiple locations depending on what we palpate at the time of that visit. If they're twitching, we treat it, it's not twitching anymore.
And that's the hard thing with those of you that are interested in participating in the study, is that to make it consistent, we have to stick to these areas and not do the whole dog, or we won't get the results we need for the data.
Right. So they understand that, and they are signing up knowing they could be sham or they could be real. And they also understand that we can't start their other treatments until after the study. And what I've offered them, and for participating in a study where they could have sham treatment and they're bringing their dog in like 5 times, I offer them 3 or 4 complementary treatments afterwards. And if they've had real shockwave, then we might do a couple of complementary other treatments, e-stim or water treadmill, or Therax or whatever manual, whatever we want to, that they would benefit from. But if they've had sham treatment with shockwave, then we offer them real shockwave treatment. In addition, we can start other treatments, e-stim and other things. But it's very hard because we're so used to lying the dogs down or standing them on a PEMF bed to treat. And my techs have literally had to unplug the box from the respond bed because we forget, and we'll just automatically turn it on. And like, no, not supposed to treat with PEMF during the study. So.
Yeah. That is a bit of the difficulty with this study, but it'll be really interesting information. So we're hoping that anybody who can will help us out in that regard.
And anybody have questions? I mean, I'm happy to. Anne's got her hand.
I do. Raise my hand. I don't ever do that. What are the exclusion factors as far as medications and supplements? I might have missed that because I joined a little late.
No, we haven't gone over it yet.
Okay.
Half an hour of time still. So
if
hopefully you guys can stay. But the medication, so they have to, so initially we had wanted them to be on an NSAID for like up to 2 months prior to enrolling in the study. And that was really hard to follow through with, because a lot of my clients come here seeking alternative pain management to NSAIDs, or have dogs that have geriatric, issues and can't take NSAIDs. So what we've done is we've made it 2 weeks prior to the start of the study date. They need to start on an NSAID if they aren't already on one. And then based on that, we, at the first intake visit, and if they're on other pain meds, they can be on all of that. They just can't change the dose or add something new while they're in the study. So for example, if they're already on gabapentin and amantadine and Adequan, they can stay on all of that, but they just have to add the NSAID in for the purpose of the study, because halfway through the study, we asked them to decrease the NSAID by 50% so that we can see, you know, do they remain comfortable based on shockwave without the NSAID? And I think that was something that was added to the study by the other collaborators because they felt that that was a more measurable outcome of evidence of pain relief by removing an NSAID. So it's tricky if you have a patient that's already on significant pain management. You know, most of these cases that are coming to me are not on much medication for pain, and they're just getting a diagnosis that they have hip dysplasia. And so I will start some of them at the same time I start an NSAID if they're severely painful. I had one that was really painful. I started him on gabapentin and carprofen at the same time. And then 2 weeks later, we started the study. And he just has to stay on the same medication throughout the study until midway through where we lower the carprofen. But they can't add other treatments midway. Like they can't midway through the study start their dog on Adequan, for example. And the other thing that's important to let clients know, because when I didn't do that one time, this happened, the dog was better. So they're like, oh, let's go on a 10-mile hike. We haven't done that in a long time. And then the dog couldn't walk for like the rest of the week. So we had to ask them what their outcome measure of pain management, you know, what's your assessment of the pain today? And they're like, it's way high. And so like that skews your study if they're doing stable behavior, stable activity throughout the study. So, you know, I think that's also important that they don't do radical changes in their lifestyle or activity levels during the course of the study, because that can create other problems and pain.
Yeah. So I'd just like to add, yes, the reason they have to be on an NSAID beforehand and then taken off halfway through the study is that is a protocol for an objective measure that had been accepted for publication with Dr. Looney in the laser world. So, you know, that's how that came about, trying to get as many objective measures as we can that everybody can do if they don't have stance analyzers, force plate and all that, you know, type of stuff. So that's where that came from.
Yeah, exactly. And I guess the other exclusion criteria that's important to know, the patient can't have any other severe acutely painful injuries. So like a dog that just had cruciate surgery within the last 6 months is not eligible because we can assume that some of their residual lameness may still be from recovery from knee injury. And if they have a systemic medical condition like autoimmune polyarthritis, or if they have cancer, for example, they can't be in the study because their change in behavior and their expression of pain could change based on their systemic illness. But that being said, I had an older patient that was on chronic levothyroxine for hypothyroidism. That's not a problem as long as the dog is stable. It's not like a new condition that's been introduced to the patient that could change the outcome measure during the 4 weeks of the study. Does that make sense? Yes. And they have to
So
have
not being,
radiographic. If they're being referred to you, they need radiographic evidence to meet the inclusion criteria. And Cindy can send you the email, the list of the study, which shows all of the things you have to, you know, look through to say, are they eligible? Do they meet criteria by having some of
Yeah, so anybody who I haven't, who is interested, shoot me a quick email and I will send you, what we have is a digital copy of these binders. And the binders do really help you follow your way through the study. I think that's an important part.
One problem for rehabbers like us is that it would be wonderful to enroll current clients in the study, but you can't really because we want them to be novel patients that haven't had other physical rehabilitation modality treatments to their hip in the past 3 months prior to entering the study. So they can't have been getting laser or TENS or manual therapy or other joint injection, things like that. So that was another challenge, was getting new patients, because I had a lot of patients I was already treating with hip dysplasia when we started the study, but we had already been treating them. So that, okay, and I see a question about large lipomas on the legs. I don't think the large lipoma on the leg is, unless it's causing pain or severe gait abnormalities, because we are trying to assess gait as an outcome measure. Do they improve their gait? We take videos before and after. So also a tripod dog with hip dysplasia on their one remaining leg, or if they're missing a front leg and they have two bad hips, that also is an exclusion criteria, because they're going to have so many other gait changes that it's really hard to evaluate. Let's see, previous hip joint injury or surgery on the hip also is an exclusion. Yeah, that's a question. Total hip, total hip replacement. Yeah. So we want a joint that's had no interventions, basically. So no prior hip joint surgery. I suppose if as a puppy they had a triple pelvic osteotomy, which I don't know how often that's being done anymore, I suppose that they might be eligible for the criteria in the study if it's been years since they had that surgery. But I think for the purpose of uniformity, we were looking for patients that did not have any interventions, so that we could use the PiezoWave treatment as a way to document that, yes, this is an effective pain modality. And yes, low intensity treatments are just as good as high intensity. You don't have to sedate the animal for it. It's not painful, it's not loud. And then there was another question that just popped up in the chat. Let's see, how often am I treating? Okay, so the treatments are, so the study involves 5 visits. And it's once a week for 5 weeks. And so the first visit, they have in the binder set it up so that there's a pre-treatment visit. I always make that pre-treatment visit also treatment number 1, because it saves the client's numbers of trips down to me without not knowing that they're actually getting therapy. So I do a pre-treatment evaluation. I block out a half an hour for my evaluation time with the tech, and then the client fills out their initial forms. They sign their consent form, they fill out their client brief pain inventory and their client specific outcome measure form. You just make sure that they are eligible for the study, although I usually do that before they come in. Yes, missing an appointment is an exclusion because they have to come once a week for consecutive treatment. So at that first visit, they'll pick an envelope to determine randomization. They pick an envelope blindly, whether it's sham or real, and then the tech will set up and do the first treatment. So we spend an hour at the first appointment. I do my measurements, goniometry, muscle assessment, gait videos, and then we do the randomization and we go over the client's requirements to maintain steady pharmaceutical dose and lifestyle activity levels, and then half an hour of treatment time. And then we schedule sessions 2, 3, and 4 just with my blinded technician for half-hour appointments. The owners can be there because they don't know the difference between a loud click and a soft clicking sound. I just can't be in the room.
So let me explain the sham just real quickly to you guys. So the way we create the sham is to not put gel in between the gel pad and the therapy source. And Germany has told us that they will put that on their machines, and that we get, less than 0.001% energy transmission. So that is our negative control. But like Dr. Strubel says, like anything, it does sound a little different. So that's, it is what it is. But that's what our sham is.
Hey, Cindy, that's also how the shams have been done for other studies with the electrohydraulic.
Yeah.
Yeah.
So, and those have all been published already, so like it's an accepted method for the sham.
Yeah, great.
Good.
So then we had a question in the chat that was directed to me privately that was asking if the patient cannot take a traditional NSAID, are they excluded from the study? And the answer sadly would be yes, because they do need to have that as part of the study for uniformity of the patients getting treatment. So I do think that, that's an unfortunate thing, but we have a few patients that just cannot take it. Let's say they might be on prednisone for another medical condition, or they have IBD and they get diarrhea or, terrible GI problems on any NSAID, even Galaprant. But, I've used Galaprant at a low dose, just enrolling them in the study. I put them on a low dose and they did okay. And since they were doing well, they stayed on the Galaprant, and we did the study with that. And actually they learned that they could treat their dog with the Galaprant and it could tolerate it, and it did better on the Galliprant than he had been without it. So that was also a benefit to the dog. And then as far as the study, that we do a 5th visit where we do the final outcome measures. So I spend an hour, a half hour where I do the video recordings again and upload those to the Dropbox folder. I do the goniometry measurements before and after, the flexion and extension of both hips, muscle assessment. Client does another brief pain inventory, and they complete another client-specific outcome measure form. And once all that data is collected and the study is technically done, then we do the reveal, and the tech gets to tell us, was it sham or real? And then we have a half hour scheduled at that visit for them to do a treatment. If it was sham, just as a thank you for participation, we offer a few complimentary treatments. And if it was sham, they can do a real shockwave, or if it's been real and they're happy with how the dog is doing, we can give them some more complimentary shockwave treatments. So.
And Dr. Strubel, can you explain a little bit about how we're trying to do the blinded gait analysis?
Yes, and I had another question that just popped up. Do treatments have to be done inside a clinic for the study? I don't believe so. I mean, if you're a mobile practitioner dragging your shockwave around, more power to you. Careful of your back. But you can't be in the room when your tech is doing the treatment. So if you're doing the measures at home and the treatment at home, that's fine, as long as you aren't aware whether it's sham or real, so that you aren't biased when you make your final measurements at the end of the study. And then the videos, we're using the video technique. There's, actually a video of how to make videos from OrthoPets for clients. But basically, the dog is with the technician, not with the owner, walking and then trotting to the left and to the right, and then towards and away. So we have video clips at the ground level, at the dog's leg level, not looking down. So you can't video, obviously, while you're walking the dog. You're videoing and the tech is doing the walking and the trotting, if they can trot. If they can't trot, then you just do the walking and try to document your assessment of what the gait, lameness scale is. But then we also are going to have a blinded surgeon outside of the study look at all the videos in the Dropbox folder and grade the lameness on the videos before and the videos after.
So that's an important part of our attempt at being blinded, is that those people who are grading the videos, they have not heard the shockwave. They haven't had any exposure. So that helps in our blinded issue. So,
I mean, it's also, as far as being biased, I mean, if it's a real shockwave, sometimes you can see the improvement in their gait just when they come in for the treatment number 2, 3, and 4. So I try to just avoid the patients so that I don't get a bias. At the end of the study, I do my measures and then I get to find out if it was real or sham. But if the owner comes in and they're like, oh my God, he's so much better. Like, sometimes that's placebo, but sometimes it could be real. So I just try not to engage with the client or the patient, and my technicians do the treatments. Yeah.
Little nuances of trying to be clinically appropriate, which are, could I say, a PIA, pain in the ass.
Yeah, but it's like clinical studies, like clinical trials. Clients want to participate in that. They're very excited about it. They're like, we want to contribute to science. We want our dog to help other dogs. When I explain it to them that this is a type of treatment modality that other people aren't using in this way, and we're trying to document that, not just treating a specific joint, but treating the muscle, and that the pets don't have to be sedated for these treatments, and also limiting the number of pulses. I know some practitioners will limit and do a treatment of 600 to 900 pulses. That's it for treating a tendon or ligament. And to me, I mean, my patients never, and Joe Thompson is going to laugh when he hears this, but he knows me very well. And my patients never leave without a minimum of 8,000, sometimes 12,000 pulses treatment to their whole body, and so we are using it this way, and we're getting tremendous results. And we have a lot of clients who come back regularly for this treatment. And if they start to stretch it out, like we do 5 sessions, just in my clinical practice, we'll set up a package of 5 treatments. And then at the end of the 5, we reevaluate how are they doing. Then we'll try to taper it to like every 2 weeks, or maybe every 3 weeks, or once a month. And many of them with this chronic osteoarthritis cases, they'll say he can't go that long. We went on vacation 2 weeks, we missed a treatment session, and we could really tell. So he needs his treatment, and it's really noticeable, even if they're on all the other pain modalities. A lot of times also, I'll treat like tendinitises that have swelling, like the Achilles insertion. That's a great one when they have Achilles tendon strain, or patella tendinitis. Those are great with the shockwave. They're fantastic. They do really well. Let's see. I have another question. How am I addressing long-haired
Can I
dogs?
ask you a quick question?
Oh, sure.
How long can the treatments go for? Like, can you treat a dog for like several years, every
Yes.
month?
Yes,
and
and I
not-
do. Yes, and I
No.
do.
With 8,000 to 12,000 shocks each month?
Yep, absolutely.
Oh,
I think
okay.
of it as deep. It's like a massage from the inside out. Now, I will say that I have a very talented CCRVN working for me who's got significant training in myofascial release, and she can affect similar changes, but the amount of change we affect with the shockwave is like we modify tissue over time. We see that some dogs that have had really twitchy TL spine from years of shifting their weight forward onto their lats and their shoulders, over time they come in and they're no longer twitching. They're feeling great. So we might start focusing treatment in other areas of the body.
Yeah, I'm going just to add to the dosing. We have to remember when we are dosing with shockwave that it doesn't build up and that it just passes through the tissue. So that's one of the reasons. And it's also local to the actual cells that the focal zone is hitting. So those are two things to keep in mind when dosing. I was just retraining a group yesterday who started 5 years ago, and they were having trouble with dosing a little bit, and they were charging by the shock, and or by the pulse or whatever. And for me, when even as a technician, when I do a treatment, I need to keep in mind the effective pulses as a technician, because my pulses might not be when I'm trying to hit the joint line exactly in the joint line, or exactly on the trigger point in that muscle. So don't be shy with the pulses is the takeaway.
And also don't be shy with the ultrasound gel. I see Eric Herman posed a question, what am I doing with long haired dogs? We use a lot
Oh my God.
of ultrasound gel, a lot of gel. And so it's like you need to get through that fur. And those German Shepherds and Corgis are the worst because they have such a dense fur, as Cindy knows, because she's a Corgi mom. But we really have to make sure that there's no air between the fur and the skin, because if you've wet the fur down with gel on the surface, but if you part the hair and it's dry underneath, you are not treating that tissue at all. It's not going to penetrate through air. So I make sure my technicians know to apply it to the target tissue and really work that gel into the fur. No, we don't shave them or our patients would be bald because we treat their whole spine. And that's another thing that people I've heard say to me. I was taught never to treat over the thorax or the shoulder, like the spine, because it can cause problems. And that I've never found to be the case. Targeted with piezo-wave, if you're using a 5 on a small dog or a 10 on a larger dog, to try to treat your multifidus muscles, your longissimus, lower spine, your quadratus lumborum. I use a deeper probes when I'm getting up and under into my psoas, quads, but I always treat the spine. Most of my patients have myofascial pain in the spine, and post-surgery, I don't treat right over like a hemilam site, but I'll treat around it because they have so much muscle trauma from the fenestration, and like we cut the muscles right off the dorsal spinous processes, and so those muscles, like, they're not happy. If you put TENS there, they're not activating. So we'll use TENS first, of course, because if we want to use e-stim, you have to do that before shockwave. Otherwise, your dog is covered in gel and you can't do e-stim. But so we'll do the e-stim first and then the shockwave.
And I wrote a literature review of what's been going on in the neuro and working around the spine, and why we totally believe it is safe to work on the peripheral nerves, and kind of the chronological how we've evolved. So if anybody is interested in that, I can send you the link. It has been posted on LinkedIn, I think, but it hasn't gotten on our website yet.
In the LS, nothing like it. You just got to go a little deeper for the chronic LS. I treat cats as well, as Joe knows too, and Cindy. And the question about the gel is, in the beginning, I was trying just to use like a scraper, like a plastic scraper, like a squeegee, basically a butter knife or something to scrape a lot of the gel out and then towel off the dog. And then they were going into the treadmill or our pool, and we were still getting so much residual gel coming off that the pool water was turning blue and getting murky. So we actually have a shower station. So we rinse off the dogs before they go into the treadmill or the pool, or if they're just coming for shockwave treatment, we rinse them off with warm water, heated shower. And then for cats, I use what I call a hot towel wrap, where I take a towel and I soak it with our shower in hot water and I wrap the cat. And then I comb them with a flea comb, and I get a tremendous amount of gel out of their fur that way. Plus they love the hot towel wrap as part of the treatment. And then let's see, Elizabeth has a question on 8-month-old cat with a fractured tib fib repair with plate, femoral head and neck ostectomy on the same side. Ooh, that's painful for the cat. Avascular necrosis in the other hip. Ooh, that's going to be another FHO soon. And fracture is non-union. Oh my goodness, this cat. Can I use shockwave in a young cat with hardware to help promote growth? Yes, Cindy's nodding her head. Yes. You may just want to avoid like focusing on the growth plates. But again, cats are pretty lean on their muscle mass, but if you use a 5 and you focus on the surrounding musculature and you're not targeting where a growth plate would be, it would be pretty hard to hit the growth plate, because you've got to, your focal point is about the size of a pencil eraser, if I understand that correctly. And so if you're fanning through tissue, moving it slightly, those of you who do like diagnostic ultrasound, if you move your probe slightly, you're like, whoop, you go to the other side of the abdomen, like your sound beam moves very, to the smallest movements to just change the angle of the probe, but just avoiding the growth plates. And then the non-union fracture, I would have to really see how much of a non-union it is. Glad you loved it, Lori. I'm happy to help anybody with cases. I'll put my phone number in the chat if you have cases or you can get it from Cindy. This is my cell phone. If you have cases you have questions about, I'm always happy to help. But I do think that for that cat with the FHO, I treat a lot of cats with FHO chronic pain. The side that has no joint, you can treat all of that muscle tissue, the psoas, the hip flexors. If the cats are really freaked out about the gel or the sound wave or the treatment, my favorite treatment for calming them initially until they get the idea that, hey, this feels really good, is I give them buprenorphine with a little tiny drop of injectable ACE. So like 5 units on an insulin syringe of injectable ACE promazine with the regular dose of buprenorphine, and I give it orally, have the client give it transmucosally an hour before the visit. Sometimes we'll combine that with gabapentin, but I find that the buprenex with a hub of ACE is one of the most sedating, calming, pain relieving, kind of relaxing pre-op, pre-treatment for outpatient for cats that I've seen so far, because you are going to have to turn up your intensity over your non-union fracture. I love this churros. That's fantastic. And fish flakes and tuna. Yeah, those things all help. They all help a lot. But I did have a few the other thing that helps a lot is weighted heated pillows that you could put in the microwave. The neck pillows that you might put around yourself, the lavender pillows, we warm them up, put them, they're a little weighted, and they kind of calm the cat. And the cats can just relax in the front half of their body if you're treating their hips and their lumbar spine. And then I find the wet heated towel over the lumbar spine and the hips later allows me sometimes to do some range of motion that there's no way in hell they would let me do if they're post FHO prior to shockwave and heat application. So I think of the wet towel, heated wet towel afterwards as part of my treatment. and combing with the flea comb to get the gel out of their fur is also, I think of that as a myofascial treatment because it is helping to break up trigger points along the surface when you comb through the fur.
Does anybody else have any questions? Because we're lucky to have Dr. Strubel for this one, and I'm so glad so many people came to join us. So any other questions that we can help you with?
I would just say for those of you who are new to using shockwave, that in this case, sometimes more is better. Like more pulses, just fanning through. You don't want to hold it in one place for too long and cause any tissue, too much inflammation is not a good thing. I know that we want inflammation to help heal, like jumpstart inflammation for non-union fractures, but I find that too much inflammation can be painful. So if you're treating a painful knee joint, like trying to treat a partial ACL and there's joint effusion, use your 5mm probe to get into the joint, push some of that fluid out, keep the pulses low, treat over your patella tendon, go up over your patella itself and try to treat at the quadriceps patella junction at the quadriceps tendon, although that's a sensitive spot in most patients. And then treat up your quads and sartorius because those are always tight and contracted. And at the proximal sartorius quads at your ASIS, you'll get tons of trigger points. And so always try to treat that area and you'll get tremendous response to your partial cruciates or your conservative management of your cranial cruciate. Do I have sites that I switched the probe size during treatment? Yes, absolutely. So let me think, for example, with the C-spine, let's say I'm trying to get facet joint arthritis on the cervical spine. Obviously I'm palpating for my facet joints and I'm not going to shockwave over my jugular vein, but I'm going to use a more shallow probe if I can palpate the facet joints. But then if I want to get into the brachiocephalicus muscle, I'm going to use a 10 or a 15 if it's a bigger dog to get into that. Oh, and the other thing I use it for a lot, although I will say be careful in cats because the stimulation to the central nervous system, I did have one older cat that was prone to seizures, have some neurological signs. But then the cat was actually so much better, is the occiput atlas, C0C1 on your vestibulitis patients. Or if you palpate, if any of you are certified in chiropractic or VSMT, if you palpate, your wing of your atlas and you have tight rectus capitis muscles on one side and your atlas is subluxated dorsal or cranial or superior, or whatever you want to call it, treating those muscles, they love it. They relax so much. And then you can do your joint mobilizations of C0, C1. And you can do, your facet joints with the 5mm probe, and then you can go back over it with a 10 over the muscles. Helps a lot with those old dog vestibular. Not idiopathic cases. They're not idiopathic. They're myofascial.
Good deal. We don't want to tie you up from your patients, but I appreciate your time. And everybody, some people have requested stuff. I have tried to write down notes, but I'm not really good at that stuff. So don't be shy. Bother me. Email me if you want anything. I can connect you to Dr. Strubel, or you can shoot her a text. And have fun out there. And let's get some exciting things done.
Yep, definitely. All right, take care, everybody. Text or email Cindy or me if you have questions. Happy to help.
Thank you.
Bye,
Thank
Cindy. Bye,
you.
Tracy. Sorry I was late getting to the appointment, to the Zoom.
Not a problem. We love your time. We appreciate it.
Okay.
Thank you.
Take care, Cindy.